Hello, I was tasked to talk about inherited arrhythmia family screening challenges in the Gulf region. My name is Mohammed Ibrahim. I'm a pediatric cardiologist and electrophysiologist at Department of Pediatrics in Kuwait University. Before talking about specific challenges, I would like to mention that genetic testing is the standard of care for all inherited arrhythmia conditions, especially that many are monogenic in nature. And by doing so, you might very well confirm a suspected diagnosis or establish a diagnosis in an unexplained case. The fundamental rule is to test the proband or a family member with the most severe phenotype. After obtaining your genetic testing or identifying your genotype, you then need to screen members at risk in the family from the constructed pedigree. This is also the standard of care. And by knowing the genotype, this would facilitate cascade screening in the family by obtaining gene-specific testing to family members at risk. You want to stop the phrase of not ordering genetics testing to your patients after a normal cardiac evaluation in an established genotype positive family, because often or sometimes the disease is concealed and sudden death might be the primary or initial symptom. So being asymptomatic sometimes is not reassuring. I would also like to mention that the yield of genetic testing varies according to the inherited arrhythmia syndrome of suspect. Long QT syndrome being the highest yield of testing, and perhaps Brugada syndrome being the least in terms of yield of testing. It is beyond the scope of this presentation to talk about genotype positive, phenotype negative individuals during family screening, often due to incomplete penetrance or variable expressivity. Also, I would not talk about phenotype positive, genotype negative families, except to say that you, as a physician, would still need to educate the family regarding the ongoing possibility of heritable syndrome that is not yet perhaps discovered, and that gene elusive families are difficult in terms of cascade screening because you need to identify the phenotype for all family members at risk. Um, instead, I would talk about specific challenges that are often encountered in our region, and I would start with an example. So this is a pedigree of a family that I recently encountered. The family belongs to a proband who presented with cardiac arrest at 47 years of age. She was diagnosed clinically as a hypertrophic cardiomyopathy case, and an arrhythmia panel confirmed a pathogenic mutation known to cause hypertrophic cardiomyopathy. But as you can see, this family is large, and this is often the case with our families. We do have often large families, which obviously would complicate the cascade screening because there are multiple family members at risk and need to be tested. This is another family that I recently encountered. As you can see, again, it's a large family. In addition, this family has multiple phenotypes. There is dilated cardiomyopathy phenotype, there is heart block phenotype, there is sudden cardiac death, and there's also ARVC phenotype. So this phenotypic diversity obviously challenges your clinical diagnosis or suspicion. And in this case, as it's recommended, arrhythmia panel was performed for the proband, showing a mutation in DES gene, which encodes for protein desmin that was not previously reported. And it was labeled as variant of unknown significance in a couple of companies. However, this patient underwent functional studies through tissue from her explanted heart at the time of heart transplantation, demonstrating desmin aggregation or aggregates, which is pathognomonic for desmin-related cardiomyopathy, and often means it's a disease-causing mutation. So as you can see here, there are desmin aggregation in the myocytes, confirming disease or suggesting disease-causing mutation. This mutation has been also studied in the lab by another group just recently in 2022, demonstrating desmin aggregation in myocytes or cells. So another proof of pathogenicity of this mutation. So a mutation that is not previously published is a common encounter in our region, perhaps because of limited publications or testing that happens in our region. This is another challenge that we face as clinicians. In addition, we meaning the Gulf region or the Middle East in general region, we are represented rarely in the genomic databases. The most extensive one being the genome aggregation database, and we only represent, for example, less than 1% of the entire samples. So as you know, every protein is encoded by genome, and there are normal changes in our genome which makes us all different. Those changes, unfortunately, are not well known in the Middle East because, again, we are underrepresented in genomic samples. And this challenges our interpretation of variant, meaning often when the variant that is identified is novel, i.e. not present in control databases, this usually is an additional evidence for pathogenicity. But because we don't know our variants well in our control databases, we cannot use this as an evidence for pathogenicity. So this, as you can imagine, complicates our genetic testing results interpretation. One of the largest studies studying Middle East individuals' genome was recently published in 2022 as well, including 2,116 individuals from the Middle East. It identified 53% variants, 53% of the variants that were identified were actually absent in genome aggregation database. So these variants were more specific to the Middle East region. And in addition, there were 39 variants that were previously reported as rare, clinically significant variants in disease databases, for example, ClinVar, were actually common and sometimes present in homozygous state in Middle Eastern population without disease. So this suggests that such variants, for example, are perhaps not disease-causing, at least for the Middle East population. So this shows how important it is to identify our genome, and this explains why non-Europeans in general are more likely to receive a variant of unknown significant result compared to Europeans, because non-Europeans are underrepresented in genome databases. Luckily, there are genomic projects that are starting in our region. For example, the Saudi genomic project started in 2014, and there's another genomic project from Qatar which started in 2015. Both aim in performing 100,000 whole genome sequencing of individuals from both countries. And there are already many novel variants that are being identified. So back to our initial example, if you remember, the proband had clinical hypertrophic cardiomyopathy phenotype, but the arrhythmia panel also also identified VUS, or variant of unknown significance, in a gene that was previously thought to cause Brugada syndrome. And this patient did not have Brugada phenotype, but nevertheless, the at-risk family members were tested for that Brugada VUS mutation, and a couple of family members were tested positive and were labeled as Brugada syndrome without having Brugada disease or Brugada phenotype. So this is another challenge that we face. We do have limited cardiogenetic expertise in the region, and it is usually recommended that you involve cardiogenetic professionals and genetic counselors when you identify a pathogenic or likely pathogenic variant in your patients to enhance the interpretation of those variants. But the problem is we do in general have significant shortage in geneticists, yet alone cardiogeneticists in the region. And also we have extremely limited Arabic speaking genetic counselors, estimated to be around 40 in the entire region, probably most of in Saudi Arabia. So we don't have we don't have, unfortunately, the manpower to enhance our services. So in general, the family screening challenges are multiple. For example, it is often difficult to convince all family members at risk to undergo testing. You need to obtain records for all family members for co-segregation analysis, but this is often difficult, especially due to lack of electronic medical systems, maybe. There are ramifications with insurances and jobs. Sometimes medication are not covered by insurances or are expensive. If the patient is self-pay, you might need to avoid specific drugs. You may need to adhere to specific lifestyle changes. You, as a patient, you might find it difficult to identify or to find physicians that are knowledgeable of your rare inherited arrhythmia syndrome. Your care in general gets complicated. It might be an issue to disclose that finding to your significant others, and the risk of inheritance to your offsprings, and generally the quality of life, school and sports are perhaps decreased. More specifically for our Gulf region, in addition to all those general concerns, we do have limited, if any, banked tissue DNA storage. Often there's no post-mortem, tissue stored. We have limited functional study capabilities, limited whole exome, whole genome sequencing. Our genetics, as we saw, are unique. We have long turnaround times, which is frustrating for the physician and the families. There is probably more social stigma. Our countries are usually small, everyone knows everyone, and perhaps some families would be labeled with a specific disease, and and there is concern for future marriages within this family. So this is definitely a concern in our Gulf region. Perhaps the blaming is more common in our region. Again, we have large extended families. There is definitely very limited genetic psychosocial counseling, and often we don't have one-stop shop, meaning the patient need to go to a different center for genetic testing, different center for cardiac evaluation, and so forth. So it's very inconvenient for the family. So in conclusion, definitely it's a standard of care to perform genetic testing and cascade family screening. And this has opened a wealth of opportunities in terms of diagnosis and management. However, also opened a Pandora box in terms of challenges. The genetic results should be interpreted with caution in a multidisciplinary clinic with experts in the field, especially cardiovascular genetics. and we really need to know our genome, collaborate, and publish our, our findings um, and anything that we discover for our patients. Thank you.